preferred first-line therapy by NCCN, while single-agent vemurafenib may be an option if the combination is not tolerated. According to the ASCO guidelines, patients with stage 4 non-small cell lung cancer and BRAF V600E mutations should be offered the combination in the first-line setting. For patients who receive targeted therapy in the first-line setting, second-line therapy should consist of standard non-driver mutation guideline recommendations. Continuing on with guidelines, on the next slide, we have MET exon 14 skipping mutations. Both Tabrecta and Tepmetko are listed as NCCN Category 2A preferred options, while Xalkori is classified as Category 2A, useful in certain circumstances recommendation. ASCO guidelines recommend offering capmatinib or tepotinib in the first-line setting. And if the patient does not receive one of these therapies in the first-line setting, it may be offered in the second line. In terms of ALK rearrangements, ASCO 2021 updated guidelines regarding patients with stage 4 non-small cell lung cancer who harbor an ALK rearrangement recommend that alectinib or brigatinib be offered in the first-line setting. The guidelines recommend that if either of these medications are not available, patients should be offered certinib or crizotinib. The guidelines also outline drug choices for the second-line setting. Lorlatinib is the second-line setting. In the second-line setting is recommended if the patient's receiving the first two. If the patient received alectinib or brigatinib in the first-line setting. If the patient received crizotinib in the first-line setting, then alectinib, brigatinib, or certinib can be offered. And in the third-line setting, lorlatinib may be offered. Moving to ROS1 rearrangement mutations, ASCO guideline recommends crizotinib or entercitinib in the first-line setting. Other options include certinib or lorlatinib. And if targeted therapy was given in the first-line setting, then ASCO recommends that the standard treatment based on non-driver mutation guidelines should be followed. Moving onward to the mutations, on the last slide of the mutations, we have RET rearrangements. Both Gavreto and Retevmo are listed as NCCN Category 2A preferred first-line options. The guidelines state that selpercatinib or standard therapy based on non-driver mutation guidelines may be offered in the first-line setting. At the time of the ASCO publication, pralsetinib recommendation in the first-line setting was provisional, pending confirmatory data. And recommendations for second-line setting for RET rearrangements are dependent on the therapy received in the first line. If targeted therapy with pralsetinib or selpercatinib were not given in the first-line setting, they may be offered as second-line therapy. And lastly, we have Ntrk fusions. Both Rozlytrek and Vitrakvi are NCCN Category 2A preferred options in the first-line setting. ASCO guidelines are also recommended entrectinib and larotrectinib in this setting, and these drugs also may be offered in second-line setting for patients with Ntrk gene fusions who did not receive them in the first-line setting. Okay. On the next slide, we have the subclasses by Apple Health Organization that fall under lung cancer. First being multi-kinase inhibitors, and that medication being Tepmetko. We have topoisomerase inhibitors, such as hicamitin, tropomyosin receptor kinase inhibitors being Rozlytrek. We have TKIs. And the main ones we'll be focusing there are Gavreto, Lorbrena, Tagrisso, and Xalkori. Moving to the first medication, we have Gavreto. In September 2020, FDA approved Gavreto, kinase inhibitor indicated for the treatment of adult patients with metastatic RET fusion positive non-small cell lung cancer as detected by an FDA-approved test. Continued approval may require demonstration of benefit in confirmatory clinical trials. Patients should be selected for treatment based on the presence of an RET gene fusion. Additionally, in December 2020, FDA granted accelerated approval for new indication for adult and pediatric patients 12 years of age or older with advanced or metastatic RET mutant medullary thyroid cancer who require systemic therapy, and adult and pediatric patients 12 years of age or older with advanced or metastatic RET fusion positive thyroid cancer who require systemic therapy and who are radioactive iodine refractory. The dosing on this for adults and, again, pediatric patients 12 years of age or older is 400 milligrams once daily. I apologize for the warnings. There is warnings for interstitial lung disease or pneumonitis, hepatotoxicity, embryo-fetal toxicity, and pediatric use. And this medication is available in 100 milligram capsules. On the next slide here, we have Tagrisso. In December 2020, a new indication was approved for the use as adjuvant therapy for tumor resection in adult patients with non-small cell lung cancer whose tumors have epidermal growth factor receptor exon 19 deletions or exon 21 L858R mutations as detected by an FDA-approved test. Again, it does have additional indications, no changes to warnings and precautions or dosage, and the availability are 80 and 40 milligrams here. This medication is not, the safety and efficacy has not been established in pediatric patients, and there is no dose adjustment for renal or hepatically impaired patients. Continuing onward, we have Xalkori, where in January 2021, FDA approved a new indication in pediatric patients 1 year of age or older and young adults with relapsed or refractory systemic anaplastic large cell lymphoma, that is anaplastic lymphoma kinase positive. Its safety and efficacy have not been established in older patients with relapsed or refractory systemic ALK positive ALCL. It was already approved for metastatic non-small cell lung cancer whose tumors are ALK or ROS1 positive as detected by an FDA-approved test. Similar to the previous medication, this medication has additional indications, but no changes to those or the warnings and precautions. In terms of the new systemic ALCL, the recommended dose is 280 milligrams per meter squared orally twice daily, and there's no adjustment in the availability as well. Okay, continuing to the next slide here, we have Tepmetko. In February 2021, FDA granted accelerated approval for Tepmetko, which is a kinase inhibitor indicated for the treatment of adults with metastatic non-small cell lung cancer harboring mesenchymal epithelial transition exon 14 skipping alterations. Again, this indication is approved under accelerated approval based on overall response rate and duration. Continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials. Very similar warnings and precautions, such as interstitial lung disease and pneumonitis, hepatotoxicity, so it is important to monitor LFTs, and embryo-fetal toxicity. The dosage is 450 milligrams once daily with food until disease progression or unacceptable toxicity, and it is available in 225 milligram tablets. In terms of additional populations, it is not, safety and efficacy has not been studied in pediatrics, and no dose adjustments for renally or hepatically impaired patients. And on the next slide for the lung cancer class, we have Lorbrena. In March 2021, the FDA approved indication was expanded from the initial accelerated approval for use in the second or third line setting to the following full approval. The treatment of adults with metastatic non-small cell lung cancer whose tumors are anaplastic lymphoma kinase or ALK positive as detected by an FDA-approved test. Patients should be selected for treatment of metastatic non-small cell lung cancer based on ALK positivity in tumor specimens. In terms of warnings and precautions, there's a risk of serious hepatotoxicity with concomitant use of strong CYP3A inducers. Similarly, interstitial lung disease and pneumonitis warning exists here as well, along with embryo-fetal toxicity. The recommended dose for this medication is about 100 milligrams orally daily, and there is a dose reduction for patients who are severely renally impaired. and the availability being in 25 or 100 milligram tablets. I'll go ahead and, on the next slide, I'll go ahead and pause right there to see if there's any questions before moving on. Okay, hearing none, we'll continue on to the next class. Magellan Health defines this class as other oncology medications. And the other is, due to the large quantity of subclasses, the background and various guidelines won't be reviewed, but they can be found in the TCR that's on the SharePoint. Under other, some of the oncology classes that fall under here are bladder cancer, central nervous system cancer, cholangiocarcinoma, colon cancer, epithelioid sarcoma, follicular lymphoma, gastric cancer, GI stromal tumors, hepatocellular carcinoma, neurofibromatosis, ovarian cancer, pancreatic cancer, prostate cancer, soft tissue sarcoma, and thyroid carcinoma. So on the next slide here, you see the we have all the subclasses by Apple Health Organization. And we have anti-neoplastics or miscellaneous combinations being Lonsurf. We have FGFR kinase inhibitors, which include Balversa, Pemazyre, and Trulicity. We have MEK inhibitors being Koselugo, multi-kinase inhibitors being Stivarga, PARP inhibitors such as Lynparza, excuse me, Lynparza, Rubraca, and Zejula. Tropomyosin receptor kinase inhibitors such as Vitracvi, and tyrosine kinase inhibitors such as Avakit, Caprelsa, Cometric, Kinloch, and Turalio. On the next slide, we have Tazverik here. So in June 2020, FDA approved Tazverik for the treatment of adults with relapsed or refractory follicular lymphoma whose tumors are positive for an EZH2 mutation as detected by an FDA-approved test, and who have received 2 or more prior systemic therapies, as well as for the treatment of adults with RR follicular lymphoma who have no satisfactory alternative treatment options. Both indications of follicular lymphoma are approved based on accelerated approval, and continued approval may be contingent on results of additional clinical trial data. As you can see, this medication does have other indications, and no changes to those indications or their warnings such as secondary malignancy and embryo-fetal toxicity. The recommended dosage is 800 milligrams twice daily, and it is available in 200 milligram tablets. In terms of patients who have hepatic or renal impairment, there is no dosage adjustment here. On the next slide, we have Kinloch. And in July 2020, FDA approved Kinloch, which is a TKI indicated for the treatment of adults with advanced gastrointestinal stromal tumor who have received prior treatment with 3 or more kinase inhibitors, including imatinib. In terms of warnings and precautions, palmoplantar erythrodysesthesia syndrome, new primary cutaneous malignancies, hypertension, and embryo-fetal toxicity do exist with this medication. The recommended dosage is 150 milligrams once daily, with the availability being in 50 milligram tablets. The safety and efficacy have not been established in pediatric patients, and there are no dosage adjustments required for hepatic or renally impaired patients. On the next slide, we have Trulicity. In June 2021, FDA granted accelerated approval for this medication, which is a kinase inhibitor for adults with previously treated, unresectable, locally advanced, or metastatic cholangiocarcinoma with a fibroblast growth factor receptor 2 fusion or other rearrangement as detected by an FDA-approved test. The presence of an FGFR2 fusion or rearrangement should be confirmed before starting therapy. Again, warnings include hyperphosphatemia and soft tissue mineralization and embryo-fetal toxicity as well. In terms of dosage, it is necessary to confirm the presence of an FGFR2 fusion or rearrangement prior to the initiation of the treatment. and the recommended dose is 125 milligrams orally once daily for 21 consecutive days, followed by 7 days off therapy in a 28-day cycle, and is available in 25 and 100 milligram capsules. Similar to the predecessor medications in this subclass, safety and efficacy has not been established in pediatric patients, and the dosage adjustment for mild, there is dosage adjustment for mild to severe hepatic impairment and mild to moderate renal impairment. On the next slide here, we have Ayvakit, where in June 2021, FDA approved an expanded indication for the treatment of adults with aggressive systemic mastocytosis with an associated hematological neoplasm and mast cell leukemia. It already, as you can see, it already had an indication for gastrointestinal stromal tumor. There's no changes to the warnings and precautions, such as intracranial hemorrhage or embryo-fetal toxicity. And the dosing for this new indication that Ayvakit has received is 200 milligrams orally daily, with various availabilities from 25, 50, 100, 200, and 300 milligrams. Again, safety and efficacy has not been established in pediatric patients. No dosage adjustment needed in hepatic or renally impaired patients. On the next and final slide here, just miscellaneous but yet still relevant information for the committee. First is a new diagnostic, medication Vitrakvi in October 2020. The FDA approved a companion diagnostic for Vitrakvi. The companion diagnostic is a next generation sequencing based Foundation 1 CDX test that can be used to identify fusions in neurotrophic receptor tyrosine kinase genes Ntrk 1, 2, and 3 in DNA isolated from tumor tissue specimens from patients with solid tumors eligible for treatment with Reauthorization. In October 2020 as well, regarding Rubraca, the PI was updated to instruct to select patients for metastatic castration-resistant prostate cancer therapy based on FDA approval companion diagnostic. If result is negative for BRCA mutation, consider further genomic testing using tumor specimens. And lastly, there being a REMS update for Turalio in February 2021. The REMS documents were updated to list GGT, ALP, to list GGT, ALP elevations and direct bilirubin elevations as a trigger for liver adverse event reporting, suggestive of serious and potentially fatal liver injury, and to align with the product label. I will go ahead and pause right there, see if there's any questions.
Umang, it's Alex here. Can I ask about two drugs?
Yeah, absolutely.
I'm just trying to figure out where certain of these new drugs that you discussed fit into the Apple Health rubric. The Tazverik, I can't figure out which category that goes into. And then the new prostate cancer drug, the GnRH antagonist, I can't figure out where that goes into.
Okay. So Tazverik is for advanced epithelioid sarcoma, not eligible for complete resection. And as I stated before, Apple Health PDL is broken down essentially by mechanism, not disease state specifically, whereas Magellan does it by disease state. And so I think that's why we had it under other, whereas Apple Health would just have it by its mechanism, which I'm trying to pull up.
Hi, Alex, this is Marissa. I'm looking at our PDL right now, and it looks like Tazverik doesn't have the Apple Health preferred drug list class assigned yet, so that will need to be updated. It will probably need to be added. Which class it would be, I'm not quite sure. I would need to make that determination, but thank you for pointing that out because that is definitely something we would want on the PDL.
Yeah, okay. Yeah, I was searching in the Excel sheet that you guys attached, and I couldn't. That and the prostate cancer drug were the only ones I couldn't find.
This is Marissa. What was the name of the other one, Alex?
The Orgovix.
Okay. So it looks like that Orgovix is on the oncology agents, gonadotropin releasing hormone receptor antagonist oral. That was a mouthful. Drug class on the AHPDL.
Okay. Does that class include, I mean, drugs like Leuprolide and the other ones that are GnRH?
Let me double check. I believe the Leuprolide, yeah, so that's the only product in that class. I believe the Leuprolide is in another class. I don't have off the top of my head which class that is, but I do know that that is on our AHPDL. It's just in another class.
Okay. So I mean, today the motion is going to say androgen biosynthesis inhibitors and then anti-androgens. So this new drug wouldn't be part of either of those categories then?
No, let me double check which class is. Sorry, this is Marissa. No, it wouldn't be in any of those classes, but I don't know. I would have to double check if it's scheduled for a future meeting because we do break up the oncology classes. I believe we reviewed some last meeting, and I don't know. We might have some reviewed for the next meeting in October, so it could fall under those classes that are either have already been reviewed or are scheduled to be reviewed.
Okay. Sounds like it's either come up or going to be coming up.
Yeah, exactly. Yep.
And Alex, this is Umang. Just to kind of pivot on the question you had about Leuprolide, the subclass in Apple Health PDL is LHR, luteinizing hormone receptor analogs. So it's, yes, for prostate cancer, but in the Apple Health PDL, it's just a different subclass based on mechanism.
Kavita here to kind of piggyback on what Alex just asked. There were a couple of ones that I couldn't find either on our PDL, and Umang didn't list them at, he listed them as first line for the specific cancer. So one was the Pomalyst for Kaposi sarcoma. I couldn't find it anywhere on the PDL.
Hi, this is Marissa. So the Pomalyst is actually in the immune modulators, thalidomide analogs. So the PDL that you guys got, the Excel spreadsheet, only includes the classes that are being reviewed at this meeting. So you don't have the complete comprehensive PDL. It's just for the classes that we'll be reviewing. So that's probably one why you may not find it, but we do have that on our AHPDL just in a different class.
Okay, so could you also confirm one more for me, Marissa? Kavita here
Sure.
again. Keytruda.
Yeah. Pull that up. So we actually, Keytruda is not assigned any AHPDL class. It looks like the reason why that's not included on the PDL is because it's an IV drug. So typically we only include oral or maybe subcutaneous formulations or products that have that route of administration on the PDL. If it's an IV, it's like kind of on a case-by-case basis, but typically we don't include those on the PDL, so it is not included on the PDL at this time.
And if it's not included on the PDL, does that mean that that is not one of the options that patients would have on Medicaid, or what does that mean?
It is still one, this is Marissa, it is still one of their options. It would just be billed through the medical benefit. So any request that we get would be really more on the medical side. Drugs that are included on the Apple Health PDL, you'll typically see come through like a pharmacy point of sale service. So that's really kind of the key difference. So even though it's not included on the PDL, it most likely, if anything, will probably be covered on the medical benefit. So it is still an option and it is still available for patients.
Thank you. That distinction is helpful.
You're welcome.
This is Lita. Ginny, are you on?
I am here. My apologies.
Okay. We do have two stakeholders.
Yes, I see Marjan Masudi and Amy Stanford. So Marjan, when you are unmuted, then you will have 3 minutes to speak. And just as a reminder to our stakeholders, if you can go ahead and give us your affiliation with any pharmaceutical company. Thank you.
Thank you. Yes, I'm Marjan Masudi. I'm Senior Director of Field Health Economics and Outcomes Research at BeiGene. And I'm going to provide public comment on Brukinsa, or zanubrutinib, which is a Bruton's tyrosine kinase inhibitor indicated for the treatment of adult patients with mantle cell lymphoma who've received at least one prior therapy. This indication is approved under accelerated approval based on overall response rate. I'll review some of the recent updates, first with the NCCN treatment guidelines inclusion of zanubrutinib. The first one is for mantle cell lymphoma. So zanubrutinib has been included as a second-line therapy option for mantle cell lymphoma in the guidelines, and this is a category 2A recommendation consistent with other BTK inhibitors for this indication. And then next, we have inclusion for chronic lymphocytic leukemia and small lymphocytic lymphoma. And the NCCN version 4.2021 was updated to reflect the addition of zanubrutinib. And so zanubrutinib was added for patients regardless of deletion of 17p or TP53 mutational status, and was added as a second-line option for patients with intolerance or contraindication to other BTK inhibitors as a category 2A recommendation. And then also for patients with del17p or TP53 mutations, zanubrutinib was added as a first-line option for patients with a similar contraindication, again as a category 2A recommendation. Third, we see addition of zanubrutinib for marginal zone lymphoma. So the NCCN updated it in version 4.2021 to reflect the addition of zanubrutinib, and it's now listed as a category 2A recommendation as an alternative to ibrutinib, which is the preferred regimen in the second line and subsequent lines of therapy. And it states as follows: consider alternate BTKI, acalabrutinib, or zanubrutinib in patients with intolerance or contraindication to ibrutinib. And fourth, we see inclusion for Waldenstrom's macroglobulinemia, and the NCCN updated its guidelines for inclusion here as a category 1 recommendation for both primary therapy and therapy for previously untreated Waldenstrom's. We also finally see that there was supplemental NDA acceptance for both Waldenstrom's and for marginal zone lymphoma. So Waldenstrom's, the PDUFA date is October 18th of 2021, and for marginal zone, it is September 19th, 2021. Note that we don't currently have these indications, so thank you so much for your consideration and time.
Thank you, Marjan. Are there any questions from the committee? I see that our next stakeholder is Amy Stanford with Pfizer. Amy, if you're there, can you raise your hand?
Yeah, can you hear me okay now?
Yes, I can hear you. Go ahead, you'll have 3 minutes.
Thank you. Again, my name is Amy Stanford. I'm a pharmacist with Pfizer Oncology Medical Affairs. I'm here to provide the committee with updated efficacy and safety information for Ibrance, the first oral CDK4/6 inhibitor. Ibrance is indicated for the treatment of adult patients with HR-positive, HER2-negative, advanced or metastatic breast cancer in combination with an aromatase inhibitor as initial endocrine-based therapy in postmenopausal women or in men, or with fulvestrant in patients with disease progression following endocrine therapy. In PALOMA-2, a phase 3 trial of postmenopausal women with ER-positive, HER2-negative metastatic breast cancer treated in the first-line setting, Ibrance plus letrozole demonstrated median PFS of 24.8 months versus 14.5 months with placebo plus letrozole. Hazard ratio was 0.58, 95% confidence interval of 0.46 to 0.72, excuse me. Overall survival data was not mature at the time of the final PFS analysis for that study. In Paloma 3, a phase 3 trial of women with HR positive, HER2 negative metastatic breast cancer whose disease progressed following endocrine therapy, Ibrance plus fulvestrant demonstrated median PFS of 9.5 months versus 4.6 months with placebo plus fulvestrant. Hazard ratio was 0.46. 95% confidence interval was 0.36 to 0.59. In the final analysis, the secondary endpoint of OS was 6.9 months longer in patients treated with Ibrance plus fulvestrant versus placebo plus fulvestrant. Median OS was 34.9 versus 28 months, respectively. Hazard ratio was 0.814. 95% confidence interval was 0.64 to 1.029. This did not reach statistical significance. In a post hoc analysis of updated OS with longer follow-up, patients treated with Ibrance plus fulvestrant still demonstrated a numerically longer median OS versus placebo plus fulvestrant. Median OS was 34.8 versus 28 months, respectively. Hazard ratio was 0.81 with the 95% confidence interval of 0.65 to 0.99. Neutropenia was the most frequently reported all-grade adverse reaction in Paloma 2 and Paloma 3 trials, 80 and 83% respectively. Febrile neutropenia has been reported in 1.8% of the patients exposed to Ibrance across the trials. One death due to neutropenic sepsis was observed in the Paloma 3 trial. Severe life-threatening or fatal interstitial lung disease and or pneumonitis can occur in patients treated with CDK4/6 inhibitors, including Ibrance. Ibrance can cause fatal harm. Advise patients of potential risk to the fetus and use effective contraceptive. For the full side effect profile, please view the complete prescribing information. And with that in conclusion, Ibrance is an oral inhibitor of CDK4/6. Thank you so much for your time and attention to provide testimony this afternoon.
Thank you very much, Amy. Committee, do you have any questions? And are there any other stakeholders?
This is Lita. I don't see any other hands raised.
Okay, thanks. So we'll go to the motion.
This is Michael Corsillis. I move that all products in the drug classes listed on slides 16 and 17 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Hi, Michael. This is Lita. Sorry, I had to update the slide numbers to 18 and 19 since that other motion was added in. So just noting for the record that the slide numbers are 18 and 19.
This is Susan Flattabo. I second the motion.
And this is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. We have on the agenda a break here. I just want to check in with Lita and everybody else around timing.
Yeah, this is Lita. We were going to break at 2:30. We came back at 12:20. So it's up to you guys if you feel like you want to break now or if you want to wait another hour.
I'm up for waiting. I don't know, how does everybody else feel?
Keep going. Okay.
Yeah.
I'm gonna stop sharing my screen, and Marissa, you can take over.
Okay, this is Marissa. Let me just load up the policies. Okay, this is Marissa. Can you guys see my screen okay?
Yeah,
Oh,
this is Judy. We can see it.
Okay, sorry, let me turn on my camera as well. Okay, perfect. Okay, so good afternoon, DUR board. This is Marissa. I will be going through the GLP One Agonist Policy that we have drafted up today. So just to give you some background, we didn't go over GLP-1 agonists in any of the drug review, so I'll be giving a pretty high-level overview, kind of just a really brief overview of the background of these. So glucagon-like peptide 1, GLP-1 receptor agonists are a class of medications that are indicated for the treatment of type 2 diabetes. GLP-1 agonists work by mimicking the functions of natural incretin hormones in the body that help lower post-meal blood sugar levels, and it is a non-insulin medication. So this policy that you see before you was really created to help guide patients to an equally effective, less costly alternative. So currently on our Apple Health PDL, we do have Victoza and Byetta preferred without prior authorization. So this policy really only applies to the non-preferred GLP-1 agonists that are currently on the Apple Health PDL. So I'll kind of go through the policy now. So we did kind of change a little bit of the language for our policies you'll see in upcoming meetings. So instead of listing the indications here in the medical necessity box, they'll all be on the side in the actual criteria itself. And we have updated the policy now to just say GLP-1 agonist or whatever drug class may be considered medically necessary in patients who meet the criteria described in the clinical policy below. And then I have also added a note here for this policy that it only applies to really the non-preferred products in the Apple Health PDL, like I said before, and then the link is here as well. So getting into the criteria for the non-preferred GLP-1 agonists, the criteria is pretty straightforward. One, they would just need a diagnosis of type 2 diabetes. The patient is 18 years of age and older. The documentation of their hemoglobin A1C or HbA1c is greater than 6.5%, and it's measured within the past 12 months. And the last criteria is history of failure, defined as inability to achieve glycemic control, intolerance, contraindication, or clinically inappropriate to all of the following listed below. And those medications can be used separately or simultaneously for a minimum of 90 days. So the four medications essentially that we would want patients to really try are metformin at the maximum or highest tolerated dose, a preferred SGLT2 inhibitor, one preferred DPP4 inhibitor, and then of course one of the preferred GLP-1 agonists that we have on the PDL. And this "and" right here, I apologize, is a mistake that should be removed. So looking at the criteria, if they meet all that criteria, the request will be approved for 12 months. We do have our blanket statement here that if the clinical reviewer sees that this is not, that they don't meet the criteria, but in their professional judgment, these products, the non-preferred GLP-1s, can still be approved on a case-by-case basis. And then the reauthorization criteria is pretty simple. It's just documentation showing that their A1C is improved from baseline. And if it's reauthorized, it will be approved for an additional 12 months. And then we have the same case-by-case statement below. And here are the quantity limits for those GLP-1s. And then the references. And then I will go ahead and move over to the forms. Let me pull that up. So this is the form, much like the other forms you've seen at previous meetings, to help with the providers when they're doing prior authorizations for these medications. Same demographic information up here, their information, medication and strength, directions, quantity day supply, asking if it's a continuation of existing therapy. We ask for their A1C at baseline, what's their diagnosis, And then here for 4, we're offering, we have this section where the provider would list out all of the tried and failed medications that the patient has tried before. So I'll go ahead and stop here for any questions from the board.
Hi, Marissa, this is Nancy. I was wondering about, I know you put the generic semaglutide, where would Wegovy fit in? Would it fall under here, or would it fall under a different policy? Is it in here?
This is Marissa.
Sorry, I'm going to jump in. Is that the one that was previously recently approved for weight loss?
Yeah, but it's still semaglutide. It's just like, under a new name. So it's just
we don't cover weight loss medication, so it's a non-covered benefit.
Got it. Okay, I just wanted to clarify that. Yeah, because it's still a GLP-1, and so
right.
Yeah. Okay.
And it's marketed under a different brand name, and I think it's even a different strength.
Yes, correct. Okay, thank you.
I had Kavita here. I just had more of the top part of the form, which is common to all forms. I had a general question about that. I've never seen a pharmacy NPI number. Is there a reason that is usually requested, or that providers are supposed to know that?
Hi, this is Amy from the pharmacy section, and this form is specific to the fee-for-service program. And so our process works slightly different than some of the other payers, where we've actually had a claim rejected and we send this form directly out to the provider. So we do have a claim already, and we populate that information already with the pharmacy's NPI and things like that. So it's not that the prescriber is expected to have that information. We have it because we're basing that off of our claim that we've already received.
Okay, thank you.
Hi, Marissa. This is Michael Corsilis. I had a question on the clinical policy. I might be reading it wrong, but it says for the 4 criteria for the number 4, history of failure, it says use separately or simultaneously for a minimum of 90 days. So is this saying that they have to try the medication for 90 days? Like what if they have adverse reactions and something like that right from the get-go?
Yeah, hi, this is Marissa. So Michael, if they have an adverse reaction to that medication, then that can still be reviewed on a case-by-case basis. So that's kind of where that statement goes in. Of course, we would take that into consideration. So if they have an adverse reaction to metformin and they didn't take it for the 90 days, then we wouldn't hold that against them because they didn't tolerate it or they had, some kind of contraindication to that medication.
Okay, great, thanks.
Yeah, no problem.
Hey, Marissa, this is Catherine. Is there a separate policy for pediatric patients?
Hi, this is Marissa. No, we don't have, I didn't draft a policy specifically for pediatric patients.
Okay, because I know at least 1 or more of them are approved for the 10 to 17 age group.
Okay. I didn't see that in my review. I might have missed it. Do you happen to know which one's off the top of your head?
Victoza is the one I'm thinking of off the top, but that may not be the only one.
Okay.
Marissa, maybe we can go back and make sure that we have the right patient ages in here.
Okay. Okay, I can do that.
This is Leah. I have a question. If you can scroll down. So this is requiring 90 days of all A through D. And just wondering the decision with the DPP-4 inhibitor with just because they have fairly inferior evidence in terms of diabetes outcomes as compared to both GLP-1 and SGLT2. So understanding that liraglutide is preferred and does not require prior auth, but I can definitely think of situations where I would want to have someone on a GLP-1 instead of a DPP-4 in the case that they didn't tolerate liraglutide for whatever reason. Just curious about kind of conversations and discussions about including DPP-4s.
Yeah, hi Leah, this is Marissa. So I included DPP-4s just because when I was looking at the guidelines, it wasn't not recommended that they be used, and there is still, like you said, they still do help with kind of diabetes treatment. So I did include it just to be all inclusive of those. And we do have some equally effective, less costly DPP-4s that are approved that I think that patients could try. So that was really the rationale of why I included DPP-4s in the criteria. But of course, if kind of to piggyback off of what Michael said, if a patient does have some kind of adverse reaction to them or any of the kind of the products that I listed in A through D, if they don't work, then we could offer exceptions, or it could still possibly be approved on a case-by-case basis if they have some adverse reaction to some of these other products or the ones that I listed.
Okay, thanks. They're just like, especially the SGLT2s and the GLP-1s, a lot of considerations in terms of comorbidities where some of these agents are such more favorable outcomes that I'd maybe just like to consider striking the DPP-4 just because it seems like a hurdle without substantive benefit. Like I only use DPP-4s in practice when I can't use an SGLT2 or GLP-1. So I don't know. I welcome other people's experience too, but in this setting, I just think that the evidence behind GLP-1s and SGLT2s are just so much better that it may be worth considering taking out the hurdle of the DPP-4. Again, I'm okay with it because there is a preferred GLP-1 and that people can prescribe liraglutide without the prior auth, but I'd be curious too to hear others' impressions and experience with that.
This is Nancy. I would concur with your observation and comments that the DPP-4 blood sugar lowering effects are not as good, and if they're already on a GLP-1, they require in practice something that provides more than what a DPP-4 can provide, and so having to select a DPP-4 which is really not going to do a whole lot just kind of I think further hinders the process is from clinical practice perspective. I mean, it is an option and it is in the guidelines, but if you're going to a GLP-1, the A1C lowering of GLP-1 is definitely greater than a DPP-4 can offer.
Yeah, Kavita here, I would third that motion. That I really end up using DPP-4s if there's just no possibility of getting GLP-1 and SGLT2 because of the inferior performance. And separately, I heard Donna state that obesity treatment is not really something that is a covered benefit, I think was the term used, but I'm almost wondering, and this is more just for discussion, is there a way to put in language here that, if we know that semaglutide's effect on lowering weight is far superior to liraglutide's, and so is there any way that we can frame the language here that, even if the A1C is okay, but we are just not getting enough weight lowering just because the obesity is so significantly associated with diabetic outcomes, whether that could be a reason to get the semaglutide authorized. So it's not specifically A1C hasn't been lowered enough, but it's that there hasn't been adequate weight loss along with the A1C achieved.
And this is Nancy. I guess one additional thing that came to mind is on the flip side, the dosing for Wegovy offers a higher dosage, and for some patients that have coexisting uncontrolled diabetes and morbid obesity, they may require higher dose of semaglutide in the Ozempic form, so that Ozempic dosage may not. Also, there may be, I guess, instances where a higher dose of semaglutide would be applicable for a patient who has uncontrolled diabetes and is morbidly obese.
So this is Donna. We wouldn't be able to cover semaglutide or even Ozempic for weight loss. This is where it gets complicated when a manufacturer has two products with the same medication with different dosages with different indications. It starts to impact rebates, and we'll start getting disputes on whether or not we're using Ozempic instead of the newer product for treating weight loss as a way to get around not paying for the new product. So that's one of the concerns that I have with allowing the higher dose. Totally understand where you're coming from about obesity. It is a conversation that we're having, within the healthcare authority. And we don't cover bariatric surgery or any of the other weight loss products. And bariatric surgery probably has the best evidence as being having evidence to have long-term outcomes. So it is a conversation, but it's just not something that we can do, even with the higher dose of Ozempic. That we're just in kind of in a sticky situation here.
Hi, this is Marissa. Did anybody else from, any other DUR board members have any kind of feedback? I did take down on my end to make sure that the age indications are appropriate, so I will double check that. I put Victoza as an example for the pediatric indication, and then considering removing the DPP-4 inhibitors from the criteria, which I do completely understand the rationale for that, so I can definitely take that back and see if we want to consider removing that.
Marissa, this is Ginny. I don't have any questions about the form. I was just coming online it sounds as if we might be at a pause or at a place where we're ready to go to the motion. So I wanted to make sure.
Yeah, so Marissa, this is Donna. I think we can go ahead and remove the DPP-4 inhibitor requirement. Okay. And, with the knowledge that we're going to include the age appropriate, the appropriate ages under number 2 for the appropriate products. I just want to be able to move forward with the policy so that we can get it approved and not have to come back again.
This is Marissa. Okay, I made that note on here, Donna. We will remove the DPP-4 inhibitor criteria on the policy. So Jeannie, whenever you're ready.
And I'm sorry, this is Ginny again. We do have a stakeholder, Mark Borns with Eli Lilly, before we entertain the motion. Mark, I see your hands up, so whenever you're unmuted, you'll have 3 minutes to share.
Hi, can you guys hear me?
Yes, I can hear you. Go ahead.
All right, thanks. Well, good afternoon, everyone. This is Mark Borns. I'm the Evidence and Outcomes Liaison here on behalf of Eli Lilly and Company. And Lilly is seeking an upgrade to preferred status for dulaglutide, also known as Trulicity. So I'm here to highlight the medical value and help ensure you all are aware of the latest data to make the most informed decisions for Washington Medicaid patients. As a reminder, Trulicity is a once-weekly GLP-1 receptor agonist indicated for adults with type 2 diabetes, and it was first approved for use in 2015. It's available as an auto-injector with a hidden attached self-retracting needle and requires no constitution or mixing. Recently, Trulicity does have a new indication to reduce the risk of major adverse cardiovascular events, or MACE, in adults with type 2 diabetes, and or patients with established CV risk factors. So Trulicity is the only GLP-1 indicated to reduce the risk of MACE events for both patients with established CV disease and for patients at risk for CV disease. And also, more recently, there are 2 approved higher doses of Trulicity, 3 and 4.5 milligrams. So additional glycemic control can be achieved without the need to switch or add additional therapy for patients previously maintained on Trulicity. Real-world evidence studies show Trulicity initiators have significantly higher adherence, are more persistent, and have lower discontinuation rates compared to once-weekly Bydureon or Victoza. Additional RWE has shown that patients prefer the Trulicity device over both the Victoza and Ozempic devices. And finally, real-world evidence shows all-cause costs and diabetes-related costs per 1% A1C reduction were lower for Trulicity initiators compared to basal insulin initiators. So Trulicity has a proven safety and tolerability profile. It's similar to the class. I'd ask for you guys to please be sure to see the prescribing information for full safety details. And thank you for this time to address the board, and I'll be happy to stay on the line and attempt to answer any questions you may have.
Thank you, Mark. Are there any questions from the board?
Jenny, this is Lita. I just wanted to state for the record that in the chat, Roy Wang wrote, does the cost benefit of switching from a preferred GLP-1 to non-preferred GLP-1 outweigh utilizing a DPP-4 inhibitor?
Thank you, Lita. Does there need to be an answer for the record to the question?
No.
Okay.
That was Roy. He's one of our pharmacy students. I'm just asking a question. So we can discuss.
Okay.
That. Thanks.
Okay, thank you. All right, so we will go ahead and look at our motion here.
This is Nancy. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 27.17.00-1 as recommended, with the 2 amendments to remove the DPP-4 inhibitor criteria and to consider adding the age-appropriate indication criteria for pediatric population-approved GLP-1 agonist.
This is Jordan Starhaug. I second.
This is Virginia Bucola, Committee Chair. All those in favor say aye.
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 Are there any opposed? And the motion carries. And we'll go to the next policy, that's serotonin modulators, antidepressants.
Hi, this is Marissa. I'm going to pull up the policy for you, Ryan. Just give me 1 second. Okay, you should be ready to go.
All right, good afternoon, everyone. This is Ryan Takatomo, and I'll be presenting the antidepressant serotonin modulators policy this afternoon. Serotonin modulators are one of our classes of antidepressants and work by altering the activity of various postsynaptic serotonin receptors in addition to inhibiting the reuptake of serotonin. For this policy, we're including 3 of the serotonin modulators drugs, which include nifazodone, vilazodone, and vortioxetine. We don't include trazodone in this because it is not used for major depressive disorder. is common now. And so with that, I think we can move to the clinical policy. So there's only one indication which the policy will cover in, again, that's major depressive disorder. So going through the criteria, serotonin modulators may be authorized when all of the following are met, or when the client is already established on the medication and the request is a continuation of therapy. For continuation of therapy, samples do not count towards the established requirement. So with criteria 1, client 17 years of age or younger may require a second opinion review with the agency designated mental health specialist from the second opinion network. And so if they're 17 or younger, then it goes to the Sun network, else they have to meet the following criteria, which includes the client is 18 years of age or older, they have a diagnosis of major depressive disorder, and they must trial and fail 3 preferred antidepressants, which are from at least 2 different Apple Health antidepressant subclasses. For example, 2 SSRIs or selective serotonin reuptake inhibitors, and 1 norepinephrine dopamine reuptake inhibitor. Apple Health antidepressant subclasses eligible to meet clinical criteria for A include the following: alpha-2 receptor antagonists, MAOIs, monoamine oxidase inhibitors, norepinephrine dopamine reuptake inhibitors, selective serotonin reuptake inhibitors, selective serotonin norepinephrine reuptake inhibitors, and tricyclic agents. So as long as they've trialed and failed 3, of which, again, 3 preferred products, of which 2 are from 3 different products that come from 2 different Apple Health antidepressant subclasses listed, and the rest of the above criteria, then it will be approved for as long as the patient or client shows a history of medication use within the last 60 days. And so with that statement, there's no reauthorization, and then we just have the dosage and quantity limits.
Ryan, hey, this is Jenny. And I have a question about that 60-day treatment within the last 60 days, just to clarify. If somebody was off medications for 2 months, but had a history that met criteria of failure of other agents, is that stating that because they weren't actively on medication within the past 2 months, they would have to retry an additional 3 agents? Or I'm trying to figure out how that would work in real life.
I think it's more of a configuration with our system. The authorization will be allowed to continue to be refilled as long as the client has those fills within the past 60 days. But once they kind of hit them, or let's say they go off medication, then they just have to meet the criteria again, which they will, since they have the history of trial and fail.
Okay, so they don't need an additional 3 new agents to try and fail. Got it.
Yes, that's correct. Yeah, they don't have to try and fail 3 more.
Okay, thank you.
With that, we can go to the form, unless we want to stay on this.
I just wanted to piggyback of what Jenny said. I'm just wondering if there's a way to clarify what you just said, Ryan, in the language there, because, yeah, like as a prescribing provider, that's how I would read that as well, is that my patient would have had to, if they haven't been on medicine in the last 2 months, then any of the previous med trials won't work. So is there any way we can clarify the language here, since it'll be part of?
And this is Jenny. I had an idea, and then it floated out of my head for how, what we might suggest. It was something along the lines of and then review of previous authorization would be conducted, or I don't know. I'm not the best with the wordsmithing.
Hey Ryan, this is Amy. Since the whole idea is kind of built around the configuration, something that we might want to consider is stating if all of the above criteria are met, the request would be approved. Ending the statement at there and saying the medication will continue to be covered within the last 60 days. And then a statement that says if there is a break in treatment, a new authorization would be required, because that's really what we're trying to get at. It wouldn't be a whole new criteria would have to be met. It's just going to stop and require you to fill out that form and give us that information again.
That sounds much more direct and easier for me to follow.
Hi, this is Marissa. Amy, can you repeat that one more time so I can just get that documented?
I probably can't say it exactly the same way, but I can try. I would say ended after approved, and then as long as the client shows no break in medication use within the last 60 days.
Marissa, this is Donna. I think a shorter way to say that would be saying reauthorization is required if the patient has a 60-day or greater, gap in treatment.
Perfect. I like what Donna said.
Hey, this is Marissa. I just want to make sure I tried typing and listening at the same time, so hopefully I captured that correctly.
I think so, and then just delete everything after approved up until reauthorization.
All right, I can just read the revised wording. So if all of the above criteria are met, the request may be approved. Reauthorization is required if the patient has a 60-day or greater break in treatment. If there are no questions with the revised language, we can move to the form to review that. Okay, and so here's the form which just helps to supplement the prior authorization process. This form doesn't specifically dictate whether or not the determination is yes or no, but it makes the process for our review more efficient. So I'll leave a few minutes to have the committee review the document, and if there are any questions, feel free to ask them.
Kavita here. Just regarding question 4, I want to make sure it asks about the length of time tried. In the policy, I'm not sure I'm seeing any language in there where there's any kind of requirement for the length of time a medication was tried. So if there is any kind of criteria that we are using for the pre-auth, I wanted to make sure I understood that.
Right now, we don't have a specific duration that a client needs to have tried these medications. But if you think that adding like a duration is appropriate, we can certainly do that.
This is Jenny, and I, as a psychiatric prescriber, I would prefer to stay away from any prescriptive length of treatment, simply because people can have pretty significant reactions even with short trials. So I would hope as long as we were documenting that and what the reaction is, that would qualify as a trial.
I would agree with that. I just wanted to make sure, like, if it's on the form, that are we looking for something in particular if we're asking the question?
This is Jordan Starhawk. The other thing that I run into often is people have transitions of care, and I'll be able to get old notes that say that they failed a medicine, but it may not actually have the dates. And I would want to trust that the providers, if they said they failed it, I think they failed it.
Mm-hmm.
Hey, Ryan, this is Amy again. I think we can easily remove that from the form.
Thank you. I want to fourth that. Just trying to go through the record and find the dates of treatment is really painful. So if it's not very meaningful, I really think we can take that out. Thank you.
All right. If there are any last, this is Ryan talking to him. If there are any last minute questions, looks like you might have a question.
Yeah, Ryan, Alex here, and I'm feeling good about the policy and the form and the great suggestions from the committee so far. But I just have a general question. I'm trying to. Is there a intent behind the policy in terms of cost or safety or efficacy concerns? Just because, you know, I'm looking at the list of drugs that we're asking people to have tried first, and MAOIs I rarely use now, and it's not a class that we tend to feel is terribly effective or safe. So this idea that we're going to have people go through those and then move to these drugs, I just want to make sure I'm understanding the reason behind this policy.
Mainly the...
Ryan, this is Donna. I think I can jump in here. One, I would agree with Alex. We should probably remove the MAOIs because there's a lot of times contraindications with starting a new antidepressant within a certain amount of time of ceasing an MAOI. Really, the intent of this policy is that we have on the PDL, we broke the antidepressants up into their subclasses based on their mechanism of action. And so the tried and failed kind of policy would be, you know, they try and fail 2 SSRIs before you can get a preferred SSRI. Doesn't make a lot of sense because if some SSRIs, you know, fail, what's the likelihood a third one's going to work? And so you would generally choose a different mechanism of action. And I know that there's certain side effects with some of the drugs that even within the same class, others don't have. So what we're trying to do is have a mechanism for us to have try and fail across the different subclasses in order to get a non-preferred drug. And this is really the only way for us to have a coherent policy to share with the plan so that everybody's doing it the same way. I don't know if that makes sense or not.
No, it does. I mean, I guess I wanted to make sure there was not like an epidemic of serotonin modulators being used or serotonin syndrome problems or that I wasn't aware of. Because these are old drugs and they're not that expensive as far as I know. But it sounds like they are non-preferred, so you have to have certain pathways for your process, which I can understand.
Well, and this is Jenny, Alex, and the two of them, you know, Vibrid and Trintellix are very new and not with any improved efficacy rates compared to, you know, when we compare them sort of head to head to SSRIs or SNRIs, which are everybody's kind of more commonly using. So, I mean, that's just another little piece to consider. They're newer and
they are new. Okay.
With the exception of the nafazodone, I believe, I don't, that's not one that's commonly used in practice, so.
Okay, okay. Well, if what we got out of my aside here was taking MAOIs out, then I'm satisfied.
Yeah, I appreciate that. I think I agree with that that observation as well.
And this is Ryan talking. I agree with the MAOIs, but removing it would give patients less options if they have used it in the past. I'm just throwing that out there. Keeping it there doesn't necessarily hurt because regardless, they still have to trial and fill 2 of the different classes. Having that there just gives them an additional option if for some reason they wanted to go down that route. But I completely understand.
Ryan, this is Donna. So again, yeah, now that you mention it, it does make sense. So they're not required to try a monoamine oxalate, an MAOI. My tongue's tied today. But if they did previously try one and it didn't work, it would allow them to then, it would count as one of their 3 products. Does that make sense?
I see. Yeah, that's another way to look at it. Yeah, I can appreciate that.
This is Catherine. Maybe you could reorder them and put it last. There's some kind of a subliminal idea that maybe it ranks up higher because it's listed second. I don't know.
It's listed second. They're just in alphabetical order.
Ah, okay.
With the exception of 4 and 5, now that I say that.
Kavita here, just kind of playing devil's advocate on this. What is the probability that there could be patients who've, maybe 15 years ago, they tried only some of the older class agents, so like a TCA and an MAOI, but they're coming in with severe symptoms, and so somebody wants to try them on one of the newer agents right away. Is that something a scenario that would come up even often? Basically, I guess what I'm just trying to avoid is that, there are 3 here, like 1, 2, and 6, which are not really typically used because they don't have great evidence for depression. And so I'm just wondering the value of leaving them on there because those are multiple classes that are not very effective.
This is Ginny, and I'll just give my 2 cents from practice, is that even somebody who's presenting, say they've been out of treatment for a decade or more and have a documented med history, it would have to, in my experience, it would have to be 20 or 30 years old for an MAOI or a tricyclic to be the primary agents that they were treated with. That, I think, going back to maybe the early 90s, most people have the first wave of treatment would be an SSRI, so it would be very uncommon. I don't know if that's helpful or not. I don't disagree with having those agents there, just because it may capture the few people that have worked with a psychiatric prescriber who is still using MAOIs, but they're extremely uncommon. I don't think I've seen one in over 10 years. I don't think I've seen a person on one. Doesn't mean that they're not out there, but yeah.
This is Jordan Starhawk. I think what we all kind of agree on is that this criteria is virtually for everybody going to mean that they take 2 SSRIs and 1 SNRI, and then they're going to be freed out for there. That's going to be the clinical part for that. And it sounds like we're debating whether or not we want to put that into specific words, that they have to do that exact pathway, or if we're allowing for this small percentage of people who might take a different pathway than that.
This is Jenny. I would say leaving the language as is at least allows us to capture that small group of people, and it doesn't seem to limit the larger group of people.
I agree.
Do we feel ready to move to a motion? Yeah.
This is Lita. For the record, no stakeholders signed up ahead of time, but if anybody would like to speak, please raise your hand. Okay, I'm not seeing any stakeholders.
Thank you, Lita.
This is Marissa.
This
I
is
just
Jordan.
updated the form.
This is Jordan Starhaug. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 58.12.00-1 as recommended, including the updated reauthorization criteria language and removal of the trial duration language from the form.
This is Nancy. I second that motion.
This is Virginia Bucola, committee chair. All those in favor, please say aye.
Aye.
Aye. Are there any opposed? And the motion carries. And we will move next to our Modafinil Apple Health Policy.
Hi, this is Marissa. Let me just load those up in just a minute. Okay, this is Marissa. The policy and the form are ready to go, Ryan, if you can see it on your screen.
Yep, this is Ryan Takatomo. Thank you, Marissa. So now we'll be going over our modafinil policy. Modafinil and our modafinil are wakefulness promoting agents FDA approved to improve wakefulness in patients with excessive sleepiness associated with narcolepsy, shift work disorder, and obstructive sleep apnea. The purpose of this policy is to provide just the criteria for the 2 FDA indications for which we cover these products. Shift work disorder is not a medically necessary indication, and so that's one of the reasons why we created this policy. We can move down to the clinical criteria. So first, with narcolepsy, modafinil or modafinil may be authorized when all of the following are met. For one, again, this is another second opinion network drug. So if the client is 17 years of age or younger, then it automatically goes to a mental health specialist from the Sun network. Else they'll have to meet the following criteria, which is they need to be 18 years of age or older, and they have to have a diagnosis of narcolepsy with excessive somnolence confirmed with the sleep study and multiple sleep latency test, and for our modafinil, trial and failure of modafinil for a minimum of 60 days. So if they meet those criteria, the request will be approved for 12 months. And for reauthorization, as long as documentation is submitted demonstrating a positive response, then they can continue to be approved for an additional 12 months at a time. Moving on to the second indication, which is obstructive sleep apnea. Our modafinil may be authorized when all the following are met. Again, for criteria 1, we have the second opinion network language. Else they have to meet the following, with criteria 2 being client is 18 years of age or older, and they have a diagnosis of obstructive sleep apnea with residual excessive somnolence confirmed with the sleep study, and there's clinical documentation demonstrating the following: that the client has achieved normalized breathing and oxygenation with continuous positive airway pressure, CPAP therapy, and that there's documentation within the past 6 months demonstrating that the client is adherent to CPAP therapy. Client is determined to be adherent when CPAP is used for 70% of nights for a minimum of 4 hours per night. That adherence language comes from CMS. And then for our modafinil specifically, they have to have a trial and failure of modafinil for at least 60 days. So for this indication, if all criteria met, then they will be authorized for 6 months at a time. We can move to the reauthorization criteria. Yep. So the products may be reauthorized when all the following criteria are met. One is documentation is submitted demonstrating a positive response, and then also documentation within the past 6 months demonstrating the client continues to be adherent to CPAP therapy. So if they meet those, then they will be granted an additional 6 months authorization. That wraps up the clinical criteria. Then we have the dosage and quantity limits. Looks like Marissa pulled up the form, which is fine. And so this form, again, is to help facilitate the prior authorization process. I'll give the committee a few minutes and open it up for questions. Thank you.
Hi, Ryan, Kavita here. For the sleep apnea indication, I'm wondering why that approval is for 6 months only instead of the usual 12 months.
I think for this one, usually our clinical reviewer has approved it for 6 months at a time. And while CPAP, I think, is usually assessed kind of annually, I think in this case, it's because with obstructive sleep apnea, the CPAP isn't fully improving their wakefulness, I guess, and so they're requiring this controlled substance as an addition. Granted, as a C4, this drug is not super prone to abuse.
One question on the policy, or I'm sorry, on the form, I guess, and policy, I didn't see the corresponding, but would it be appropriate to, under the OSA diagnosis, to say or cannot tolerate CPAP therapy? Just because there's a number of people who just are not able to tolerate, and so that would exclude all of them. And I welcome kind of feedback on that. I don't prescribe this medication very often, so there may be reasons why you want to require CPAP.
This is Donna. Describe to me like what it means to you is to not tolerate CPAP. Is it, I know some people, are they unable to sleep because the machine is annoying to them, or is it the pressure, the positive pressure?
There's a variety of different things. Some people just can't keep the mask on, whether it's claustrophobia or they've tried a number of masks. Sometimes it's so drying, even with the humidifier, that people just can't tolerate it. So I have a number of patients, for example, who have very clear indications for CPAP because of uncontrolled atrial fibrillation, and they've worked with sleep medicine very diligently and just have not been able to use CPAP. I recently had a patient who just got an Inspire device because of his inability to tolerate CPAP. So and I guess that would be the other question, is there are some, some people use dental appliances, which don't have as good of evidence, but sometimes is an option if CPAP really isn't working. And then there are these newer interventions like the Inspire device that can be used as well. So I'm just wondering whether limiting to CPAP therapy precludes some people who truly don't tolerate the therapy from being able to be treated.
Kavita here. I guess one of my concerns with that might be that if they are not tolerating CPAP, which I definitely have quite a few of those patients, I always worry about how much cardiovascular risk they have inherently because their sleep apnea is not treated. And then if we are adding a stimulant medication on top of that, I don't have the numbers off the top of my head, but I understand that stimulant medications do increase cardiovascular risk, the stimulant, arrhythmia risk specifically. So I'm just wondering clinically whether that would be safe, not being on CPAP and then adding a stimulant.
I would have to review evidence. I'm not sure, and that's kind of why I asked in terms of, I guess my question would be, should we expand the definition of OSA treatment or therapy, especially, and I don't know the data on this Inspire device, but this came up in clinic recently, and it's at least very effective for this particular patient. So with new kind of newer therapies for sleep apnea, wondering whether that should be expanded. And maybe this is something that just needs a literature review and or kind of expert input. And also happy to keep as is if everyone feels like that's appropriate.
Hi, it's Ron Takatomo. I guess when I kind of think of this, I think it kind of makes sense that there might be a subset of patients who can't tolerate CPAP therapy. I just wonder if using this medication will prevent them from actually further going in to get alternative treatments to treat the root cause, which is their OSA, and that might have to be like surgery. So those are kind of some of the things I'm balancing while thinking about this topic.
And as Kavita here, I just wanted to make sure the question I asked earlier, where the request will be approved for 6 months. So I wanted to make sure I understood that correctly. So you're saying that there's a separate clinical reviewer who decides that time interval for approval intervals? I'm just trying to understand why 6 months for this and 12 months for narcolepsy.
Hi, it's Ryan Takatomo. Yes, so the feedback from, at least for our fee-for-service reviewer, was that in the past, before this policy existed, they've typically approved it for 6 months at a time. And whenever there's a re-out, they typically request it just to ensure that the CPAP is being used. Because if they're not using their CPAP, then that could be an alternative reason for why they're being sleepy and need this wakefulness medication. So this is Ryan Tucker. I think I think we'd be okay. I'm okay with keeping the CPAP therapy, and it should hopefully incorporate a majority of patients. I think the important thing is that their OSA is being treated adequately, which is CPAP. Modafinil is not a therapy to actually treat OSA. It's more to just address if they're continuously sleepy. And then we do have the language at the bottom saying that this drug can be approved on a case-by-case basis if they are not able to tolerate CPAP, and maybe they have a potential reason that they don't want to seek alternative therapies such as surgery. Any thoughts on that?
I'm okay with that. I'd be interested just from a sleep medicine specialist perspective of whether there's something for C of kind of an effective non-positive airway pressure therapy, whether that might be reasonable, because I do think this hypoglossal nerve stimulation is an option and has some evidence that with significant improvement. So I could see someone in that category potentially still being a reasonable option for modafinil. And then the other thing that I would just recommend is I think we should change this to positive airway pressure therapy to incorporate BiPAP, because as is written, it's actually excluding BiPAP.
So this is Donna. So what I think what we'll need to do if we're going to add any other therapies outside of CPAP, we'll have to go back and make sure that they're covered before we can recommend that we add them. I just, out of the abundance of caution, I don't want to agree to put something in the policy and then it's something that we don't cover. So we'll have to consult with our the healthcare services folks within the agency and just make sure that we're inserting the right therapies.
That makes sense. Thanks.
This is Jenny, just checking in if there are any more questions on the policy. Oh, I guess, Ryan, you probably want to go to the form. I didn't let you do that. And were there any questions here? Or does everybody feel satisfied with where we are? Okay, sounds like we're ready to look at the motion then.
And Jenny, this is Lita. Just for the record, no stakeholders signed up. If anybody would like to speak, please raise your hand.
So this is Donna again. I have a question. So if we consider the BiPAP and the other non-positive airway pressure treatments, are you okay with us just moving forward without bringing it back? Or would you like us to bring it back? My question is if you want us to bring it back, there's no need to pass a motion.
This is Jenny. Maybe Leah, do you mind responding to that?
Of course. Yeah, I'm totally fine with that. Thank you.
Okay. So,
with not bringing it back.
With not bringing it back. So we're okay. You are in agreement with us going to the motion, unless there's anybody else that would like to see it come back another time. Oh, okay. We're good.
I think, Marissa, though, that should say non-positive airway pressure. Thank you.
This is Susan Flattabo. I move that the Alpha Health Medicaid program implement the clinical criteria listed on policy 61.40.00.AA-1 as recommended, with the addendum to consider adding BiPAP and non-positive airway pressure devices if covered by ALPA Health.
This is Leah Marcotte. I second that motion.
And this is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And it looks like that is the end of our agenda for the DUR board for August 18th. So we can go ahead and adjourn. Lita, do you have any announcements for us?
I do not have any announcements, but thank you all. I'm glad we ended early.
Thanks, everybody. Good to see you. Have a good rest of the summer.
Thank you.
You too.
Bye.
Bye.
Thank you.
Thanks
Bye.
all.